This seminar is on inborn errors of metabolism. Inborn errors presents unique challenge to urgent care, emergency medicine, critical care, and primary care providers. Even though these disorders are rare, cumulatively their incidence is 1 in 784 to 2,555 infants. In a large emergency care facilities or large volume practices, you will see the patients during your practice. Failure of starting appropriate therapy can lead to death or permanent disability. With modern advancement, many of these children can otherwise thrive well. There are important three questions one needs to keep in mind or need to answer right away. When to consider inborn errors as a potential diagnosis? What are the lab studies needed? What general therapies to consider? First question is when to consider inborn errors. Any sick neonate or children without clear cause. Children with unexpected lab abnormalities. Most of these patients present with irritability, lethargy, vomiting, hypotonia, and sometimes seizures. It is unusual to have inborn errors to present as a single neurologic symptom. Most of the time, since all the brain functions are affected by inborn errors, they have generalized signs and symptoms. But actually, there are exceptions like pyridoxine-dependent seizures. Infant may mimic sepsis with altered mental status. That is a typical presentation. They often have hypoperfusion, hypoglycemia, and or acidosis. Another common manifestation or sign or symptoms of lab abnormality is hyperammonemia. The hyperammonemia can cause cell death. Indirectly, it can cause cerebral edema because of different pathophysiological mechanisms. It can present as vomiting, lethargy, seizures, or coma. Hypothermia can be the presenting sign. Milder forms can be presented as episodic psychiatric symptoms, learning disabilities, and sometimes stroke-like episodes. They can have tachypnea, either it is because of the compensatory response to acidosis, sometimes because it's central stimulation that could happen because of hyperammonemia. Some patients present with vomiting and liver dysfunctions. Primary cardiac dysfunction is less common, but in some fatty oxidation disorders, primary arrhythmias and conduction abnormality are seen. Global cardiac dysfunction is seen secondary to acidosis and other metabolic stress. The history taking is very important, especially prenatal complications such as HELP, consanguinity, and other children who died during infancy can indicate inborn errors of metabolism. So 5 important things one needs to consider. Run diagnostic testing, shut down the catabolism because most of the inborn errors, or all of them, will manifest once we introduce food. Administer supportive care, remove toxic metabolites, and consider sepsis and treat till the cultures are negative. The common blood tests obtained in inborn errors are as follows: venous blood gas, blood sugar, comprehensive metabolic panel, clotting studies, ammonia level that needs to be sent in heparinized tube and ice, urine analysis, plasma amino acids, urine organic acids, orotic acids, and amino acids, plasma free and acyl carnitine, and urine reducing substances. Not all of them needs to be sent to the lab immediately. Some of them can be archived while we know exactly what we are dealing with. How the nutrition reveals the underlying enzymatic defects. Let's look at the carbohydrate. Once the food is introduced, things like galactosemia can present as hypoglycemia, and metabolic acidosis. The most important thing is these patients do not have ketones in urine. And the other spectrum of carbohydrate errors in metabolism is glycogen storage disease. There are multiple numbers available. They also present like hypoglycemia, lactic acidosis. In those patients, urine ketones will be positive. The fat metabolism, there are two groups, fatty acid oxidation disorders and carnitine shuttle defects. Any kind of acyl-CoA dehydrogenase deficiency, whether it is medium chain, long chain, or very long chain, all will have elevated ammonia, hypoglycemia, lactic acidosis. Most notoriously, they have hypoketotic or non-ketotic. The carnitine shuttle defect as a result of carnitine palmitoyltransferase 1 defect. They will have hypoglycemia, lactic acidosis again. They will have hypoketotic or non-ketotic states. In protein side, you will have either urea cycle disorder, organic acidemia, or amino acidopathy. Urea cycle disorder, the most common defect you will see has OTC, ornithine transcarbamylase deficiency. They have markedly elevated ammonia. Respiratory alkalosis, ketosis will be negative, glucose will be normal. In organic acidemia, elevated ammonia, but not to the level of urea cycle disorder, anion gap acidosis, ketones will be positive. In amino acidopathy, like maple syrup urine disorders, everything will be normal, meaning ammonia, glucose, and the acid base will be normal, and urine will be negative. They will present like acute neurologic dysfunction. How to approach patient with metabolic disease? Check glucose. If the glucose is normal, look at the blood gas. In urea cycle disorders, you will have respiratory alkalosis. Ammonia will be very, very high. In addition, they will have abnormal clotting factors and elevated liver function test. Another group is blood gas will show anion gap metabolic acidosis, notoriously seen in organic acidemia. Ammonia level will be high, but not to the level of urea cycle disorders. When the glucose level is low, check the urine or serum ketones. If it is none, most likely lead to the FAO deficiency, fatty acid oxidation disorders. They will have lactic acidosis, hypoglycemia, no ketonemia or hypoketonemia, and elevated CK liver function test. When the ketones are present, you look at carbohydrate metabolism, normal ammonia, and metabolic acidosis. The liver functions may or may not be elevated. Once you have suspicion of inborn errors of metabolism, number one, you need to do shut down the catabolism. Glucose administration serves multiple purposes. One, it treats hypoglycemia and it provides energy source and it shuts off catabolic processes. Hypoglycemia, even mild, should be avoided in all infants who present to the emergency or urgent care because it can cause reversible neurologic damage. After the correction, they should be started on maintenance 10% dextrose, sometimes 15% dextrose if you think the underlying abnormality is fatty acid oxidation disorders or when the hypoglycemia is so severe. Another modality one can use is intralipid administration. Again, it acts like an energy resource and shut off the catabolic process. In stress states, the caloric requirements are 20% higher than at baseline. Other interventions one need to do is treat the severe acidosis because it can cause cardiac dysfunction and cardiovascular collapse. Fluid resuscitation, sodium bicarbonate when the acidosis is so severe, and when there is a refractory acidosis, dialysis needs to be done sooner than later. The second one is remove toxic metabolites. Removing toxic metabolites is part and parcel of treating these patients. To remove branched-chain amino acids that happens in maple syrup urine disease, organic acidureas, and urea cycle disorders. Hyperammonemia needs to be treated with a combination of IV sodium benzoate and sodium phenylacetate and arginine hydrochloride. If ammonia level is above 500, one should start hemodialysis on this patient. It's very important to remember it is the duration of hyperammonemia, not the specific level, that causes devastating neurologic damage. Other important medicine one should consider during the treatment of inborn errors is carnitine. In defects of fatty acid oxidation disorders, carnitine halts lipolysis and helps convert important toxic compounds into usable forms for the Krebs cycle. And also, it is safer to carnitine. It doesn't have a side effects, and it is beneficial in various inborn errors. So, routinely giving carnitine is not a bad idea. In organic acidemia, native carnitine binds to excess organic acids and is excreted in urine, creating secondary carnitine deficiency. Routinely giving carnitine when you have a suspicion of inborn errors is not a bad idea. The other important things one should consider is infection, because sepsis can mimic metabolic disease. So when the patient presents hypotonia, lethargy, and one should not only work towards inborn errors and also draw cultures and start them on antibiotic. Second, even those patients with inborn errors are susceptible to infection, especially those with liver disease. Galactosemia notoriously has a predilection to get infected with E. coli. So prompt initiation of antibiotics needs to be done right away. So these are all the common drugs used in the treatment of inborn errors. The first three are not only energy resource and also treat hypoglycemia. 10% dextrose, the dose we use in neonates is 2 to 4 ml per kilo. It corrects hypoglycemia and shut down the catabolism. Insulin, 0.05 to 0.0 unit per kg per hour. It's anabolic hormone, correct hyperglycemia, and from exogenous glucose replacement, and also can be used in situations like hyperkalemia. Intralipid, given at 3 gram per kilogram per day IV emulsion, it provides caloric requirement during the time of physiologic stress. Sodium bicarbonate, used to correct the metabolic acidosis often seen in patients with organic acidemias. The dose is 1 to 2 milliequivalent per kilo. Carnitine replaces carnitine loss, helps fatty acid oxidation, and also used in organic acidemias. The dose is 50 to 100 milligram per kilogram IV bolus. Aminol, which is a combination of sodium benzoate and sodium phenylacetate, it allows the urinary excretion of ammonia, and there is hyperammonemia, meaning more than 200 needs to be started, 250 milligram per kilogram IV over 1 to 2 hours, then 250 milligram per kilogram IV over 24 hours. Second is arginine. It scavenges ammonia. The dose is 200 to 600 milligram per kilogram IV. It is used in uric acid, urea cycle disorders. The biotin dose is 10 milligram IV or PO in metabolized amino acids used in organic acidemias. Thiamine, used in maple syrup urine disease, the dose is 25 to 100 milligram IV. Vitamin K in carbohydrate disorders to reverse the coagulopathy and found in some carbohydrate disorders, 1 to 2 milligram intramuscular in infant, in child 5 to 10 milligram intramuscular. Disorders of fat metabolism. Again, there are two important categories: beta oxidation of fatty acids, medium chain, long chain, or very long chain acyl CoA dehydrogenase. Carnitine metabolism, especially with carnitine palmitoyl transferase deficiency. The hallmarks of the fat metabolic disorder is in hypoketotic or non-ketotic hypoglycemia. These patients often present with acidosis along with hypoglycemia. It often revealed when there is a prolonged fasting or decreased oral intake. Clinically, they present as hypothermia, hypotonia, seizures, coma, lethargy, hepatomegaly, rhabdomyolysis, myopathy, dysmorphic faces, and developmental delay. The lab findings in fatty acid oxidation disorders are as follows. They will have hypoglycemia, no ketones, and metabolic acidosis. Liver function tests will be elevated, so does CK. Ammonia is elevated, but not to the extent of urea cycle disorders. The management: treat hypoglycemia. Delays can lead to sudden death or worsening cardiac arrhythmias. And give carnitine. The altered mental status may take few hours to resolve even if glucose is stable because toxic metabolites needs time to be metabolized. So treating hypoglycemia and providing carnitine is important in treating fatty acid oxidation disorders. Disorders of carbohydrate metabolism. There are 11 inherited disorders of glycogen metabolism. It's divided into two groups: hypoglycemic events with buildup of glycogen, those that affect glycogen breakdown in muscle leading to muscle breakdown but euglycemia. GST type 1, meaning G6 phosphatase or glucose 6 phosphate transporter deficiency, leads to derangements in glycogenolysis and gluconeogenesis. GST3 leads to glycogen accumulation in liver, cardiac, and skeletal muscle. The lab findings in GST disorders are as follows. GST type 1 will have a neutropenia, hypoglycemia, metabolic acidosis, and elevated uric acid. In addition, they can have ketones in the urine. In GST type 3, CBC would be normal. They can have hypoglycemia. Predominantly, they have metabolic acidosis, ketones, and elevated AST, ALT. How do you treat them? Hypoglycemia needs to be treated with dextrose followed by maintenance D10 or D12.5 or D15 dextrose solutions, sodium bicarbonate to treat the acidosis. The long-term patient needs to be on complex carbohydrates such as cornstarch or continuous feedings to prevent hypoglycemic episodes and monitor them for liver disease. Galactosemia, it's caused by galactose 1-phosphate uridyl transferase deficiency, inability to metabolize lactose into its components like glucose and galactose. It leads to osmotic swelling and eventual liver and brain dysfunction. They present like vomiting, lethargy, and jaundice. They usually develop these symptoms around 5 to 10 days of life. These patients, untreated, can present like poor weight gain, hepatomegaly, and marked encephalopathy. Some infants may develop cataract. In the United States, galactosemia is routinely screened at newborn, so you do not see that much of untreated galactosemia later on in life. But lots of other countries, including United Kingdom and Netherlands, they do not screen those newborns in their countries for galactosemia. The lab findings in galactosemia or CBC would be normal. They will have hypoglycemia, metabolic acidosis, elevated bilirubin, elevated AST and ALT, and blood culture will be positive for E. coli. These patients are notorious to develop E. coli septicemia, so they need to be cultured and treated till the cultures are becoming completely normal or completely treated. The management is immediate discontinuation of all lactose-containing formulas or breastfeeding, and treat hypoglycemia. Evaluate for E. coli sepsis, meaning drawing cultures from blood, urine, and CSF, and start appropriate antibiotic and monitor them for liver function. Next is hereditary fructose intolerance. Aldolase B deficient leads to accumulation of fructose 1-phosphate, unable to perform glycogenolysis and gluconeogenesis. The hypoglycemia usually happens after ingestion of fructose, sucrose, or sorbitol. Where are those available? It is present in apples, grapes, watermelon, asparagus, peas, zucchini, and honey. They contain fructose, sucrose, and sorbitol. Clinically, they present like vomiting, poor oral intake, abnormal movements, seizures, and pallor. So very important to get proper history taking that will give a clue to hereditary fructose intolerance. The lab findings are as follows. CBC will be normal and blood sugar will be low. There will be metabolic acidosis, elevated lactate, and urine analysis might show elevated protein, and there will be elevated liver function tests like bilirubin, AST, ALT, albumin will be low, PT, PTT, and INR will be prolonged. How do you treat them? Again, address hypoglycemia. Same 10% dextrose, 2 to 4 ml per kilo, followed by continuous infusion. These fatty acid or fat metabolism disorders often require higher amount of dextrose. Those patients may need central line right away. The avoidance of fructose, very important. And also things like sorbitol, it's often used as an additives that needs to be avoided too. And treat coagulopathy with intramuscular vitamin K. Clotting factor replacement only if there is a life-threatening hemorrhage is suspected. Fructose biphosphatase deficiency. Fructose 1,6 biphosphatase is absent or deficient in these patients. It is very important for gluconeogenesis. As a result, it causes accumulation of pyruvate, lactate, and acyl-CoA buildup. These patients present as life-threatening hypoglycemia with metabolic acidosis. It's often precipitated by fasting. These patients present as apnea, hyperventilation, hypotonia, lethargy, tachycardia, and tachypnea. The lab findings in fructose 1,6 biphosphatase deficiency, they will have hypoglycemia, elevated lactic acid, metabolic acidosis, urine ketones positive, and elevated liver function tests like bilirubin will be high, uric acid will be high, albumin will be low, and PT, PTT, INR will be deranged. How do you treat them? Again, address hypoglycemia with IV glucose and resuscitation with fluids and usage of sodium bicarbonate to treat acidosis. Treat coagulopathy with intramuscular vitamin K administration. Pyruvate disorders often caused by pyruvate dehydrogenase or pyruvate carboxylase deficiency leads to excess pyruvate in multiple tissues. Both can lead to severe metabolic acidosis. These pyruvate disorders have X-linked inheritance. That means neonatal males are affected more than others. Both the disorders have hypotonia, seizures, lethargy, apnea, and encephalopathy in the newborn period. The lab findings are as follows. They have metabolic acidosis, no hypoglycemia. Metabolic acidosis in the blood gas, elevated lactic acid, urine analysis would be normal, elevated liver function tests. The management, again, correct metabolic acidosis with IV glucose, fluids, and sodium bicarbonate. These patients respond well with thiamine, is a pyruvate dehydrogenase cofactor, dose is 10 mg per kg per day. Biotin is a cofactor for pyruvate carboxylase, should also be administered at the dose of 5 to 20 mg per day. Finally, disorders of protein metabolism, otherwise called amino acidopathies. Defect in amino acid breakdown led to accumulation of intact amino acids. The most common amino acidopathies are as follows: PKU, as a result of phenylalanine hydroxylase, MSUD, or maple syrup urine disease because of branched chain alpha ketoacid dehydrogenase deficiency leading to the accumulation of leucine isoleucine and valine, homocystinuria and tyrosinemia as a result of deficiency of fumarate acetoacetate deficiency, resulting in tyrosine accumulation in case of tyrosinemia. In PKU, often these patients present as a slow, progressive neurotoxicity. The rapid neurologic decline is seen in patients with maple syrup urine disease. Tyrosinemia often present as liver failure. PKU, if it's identified early and treated properly, they will lead a full productive life. Again, the PKU is in the newborn screening in the United States, oftentimes picked up very early on, and they are put on very restrictive diets. Poor management will lead to developmental delay, intellectual disability, and or seizures. Maple syrup urine disease symptom begins when the protein is introduced. They will have poor feeding, encephalopathy, and abnormal movements. It can progress to coma and death. Homocystinuria usually does not present as acute metabolic crisis, but they can have acute thrombotic events. So any patients with, especially in children, has a thrombotic events needs to be investigated for homocystinuria. Tyrosinemia can present with neurologic symptoms and episodes of liver failure. Other manifestations of protein metabolic disorders or clotting disorders, ascites, bacterial peritonitis, GA bleeds, and renal tubular acidosis. These are the lab findings in most common acidopathies. In PKU, the outstanding feature is urine odor, which is mousy. And AST/ALT will be normal. Ketones positive, they will have a global neurologic decline. Usually, it's a progressive neurologic decline in PKUs. They will not present, or most of the time, they will not present as an acute metabolic crisis. MSUD, on the other hand, they will present like acute metabolic crisis. They have elevated ammonia, metabolic acidosis, elevated lactic acids, and ketones will be positive in the urine. They will have a maple syrup odor in their urine, positive ketones, and the episodic acute neurologic signs. They often present as soon as the protein nutrition is introduced into the patient. That's most of the time it's a newborn. In tyrosinemia, the CBC will be normal. They can have metabolic acidosis, elevated lactic acid. The reducing substance will be positive in the urine. They have sweaty feet odor. Ketones will be positive. They often present like liver failure, renal tubular acidosis, with or without encephalopathy. So how do you treat them? PKU rarely requires emergency management, so it needs to be screened early on so that we can identify and prevent progressive neurologic delay. Maple syrup urine disease, halt protein intake. Across the spectrum in inborn errors, keep them NPO and shut down the catabolism with insulin, glucose, and lipid emulsion infusion. Avoid hyponatremia because it can cause or accentuate cerebral edema. Use isotonic fluids. Consider mannitol or hypotonic saline for signs of cerebral edema. The initial signs may be very subtle, like nausea, emesis, irritability. Later on, it will become seizures, coma, and death. Some phenotypes respond to thiamine administration. So thiamine administrations can be given in suspected maple syrup urine disease. If there is a severe neurologic presentations, patient must be treated with emergent toxin removal procedures such as hemodialysis or exchange transfusions. In my experience, most of these patients need one of these removal procedures like dialysis and exchange transfusion, in addition to halting the protein intake, shut down the catabolism, and treating serum sodium, etc. For tyrosinemia, again, stop all protein intake, start oral nitisinone NTBC at a dose of 0.5 milligram per kg per dose every 12 hours. It halts liver damage. It may prevent the need for liver transplant, supportive care for liver failure. Then organic acidureas. It's characterized by inability to break down deaminated amino acids. They will present with profound metabolic acidosis with an anion gap. The disorders associated with organic acidureas or isovaleric aciduria, biotinidase deficiency, methylmalonic acidemia, and propionic acidemia. Glutaric acidemia often present as a neurologic crisis. The others can present as metabolic acidosis. The neurologic symptoms associated with organic acidureas are hypotonia, abnormal movements to lethargy, seizures, and coma. Often they will have like abnormal movements like boxing and paddling motions you can see. The stroke can occur in methylmalonic acidemia and propionic acidemia. Glutaric aciduria often present neurologic symptoms. Catabolic crisis occurs during GA infection, febrile illness, vaccinations, and surgeries. So if there is a preceding history of this one has to think in terms of could it be inborn errors of metabolism. Children with glutaric aciduria are vulnerable to crisis until the age 6. They can present like dystonia, movement disorders, hypotonia, and evidence of basal ganglia damage on imaging. Glutaric aciduria often present as subdural hemorrhage, often confused with non-accidental trauma. So when you look at the lactic acid, it will be elevated, metabolic acidosis will be present, and of course, when you investigate for glutaric aciduria, it will be positive. Methylmalonic acidemia present as metabolic acidosis, ammonia will be elevated, and elevated uric acid. They can present like stroke. Propionic acidemia, they will have a pancytopenia when compared to other organic aciduria, metabolic acidosis, elevated ammonia, mildly elevated lactic acid, and elevated uric acid. They can present as pancreatitis. So how do you treat all organic acidurias? Again, stop catabolism, IV glucose replacement, and insulin, carnitine supplementation, alkalinization of urine with sodium bicarbonate. Seizure treatment needs to be treated with phenobarbital or phenytoin. Do not use valproate across any inborn errors of metabolism. Treat dystonia with benzodiazepines. Treat hyperammonemia with sodium benzoate or sodium phenylacetate, and arrange for emergent hemodialysis if the ammonia level is more than 500. Consider vitamin B12 or biotin administration because these are all indicated in methylmalonic acidemia. Dialysis for refractory metabolic acidosis and also for ammonia level more than 500. Finally, urea cycle disorders. Derangements in any of the 6 enzymes responsible for degradation of nitrogenous waste leads to elevated ammonia. They present with vomiting, altered mental status, and encephalopathy and can lead to coma. The urea cycle disorders will have a higher ammonia level than other inborn errors. Often happens in patients who had prolonged fasting, excessive protein intake. It precipitates hyperammonemic crisis. They present with vomiting, abdominal pain, seizures, encephalopathy, and behavioral or other psychiatric issues. The most common urea cycle disorders are OTC, ornithine transcarbamylase deficiency, or citrullinemia. Citrullinemia often present as liver failure the first 3 months of life. Lab findings in ornithine transcarbamylase deficiency is in CBC, they will have thrombocytopenia, like GSD type 1 will have neutropenia. And elevated ammonia will be very elevated. Blood gas will show all closets instead of instead of metabolic acidosis that's seen in organic acidureas. Lactic acid will be normal, urine analysis will be normal, AST, ALT will be elevated, and PT, PTT, and INR may be abnormal. The most important thing is markedly elevated ammonia levels. They present as poor feeding, vomiting, tachypnea, lethargy, hypotonia, and apnea. How do you treat? Reduce the catabolism with glucose and insulin. All these patients need to be kept, NPO, and treat hyperammonemia, sodium benzoate, sodium phenylacetate, and arrange emergent dialysis for levels greater than 500. Usually, the sodium benzoate, sodium phenylacetate is started when the ammonia level exceeds more than 200. This concludes the talk on inborn errors of metabolism. Thank you for listening.